Awesome. Here we go. So, welcome everyone to another subspecialty or Rafael Medina subspecialty Neuro VMR this time. We have an amazing guest back on the community, Dr. Helen Shi, who is going to be discussing an amazing case presented by Sam Berry, member of the Academy, and on the hot seat as well with Sarah. So, yeah, we have a full female team today, also on the backstage, scribing and doing teaching points. But without further ado, I will let Dr. Shi introduce herself.
Hello, good evening, everyone. I am Helen Shi. I'm one of the neurohospitalists at Emory University Hospital in Atlanta, Georgia, and I'm very excited to be here. Thank you for having me.
And I'm Sarah Blaine. I am a medical student at Emory, a fourth year applying into neurology. This is my second time being on the hot seat discussing, so I'm very nervous, but also very excited.
And I'm Sam. I'll be presenting a case today. I'm a fourth year medical student up in Portland, Maine. Um, I had so much incredible learning when I was taking care of this patient, and I'm so thrilled to be passing that on to you all today. Full faith in Sarah to solve this one, and Dr. Shi as well. Very much looking forward to it.
Amazing. Okay, so for people that may not know me, I'm Vale. I'm one of the members of the academy as well. I'm going to be doing teaching points, and I just want to say that I'm also going into neuro. And I pass the mic to Simi, who is describing.
Hi everyone, very excited for Neuro case and so happy to have you, Dr. Shi. Excited to scribe today.
Amazing. So I think we can get the whiteboard up, and Sam, you can start with the first aliquot.
Absolutely. Our patient is a 34-year-old female, and she's here to see you with 2 days of left hand numbness and left-sided weakness.
All right, Dr. Shi, do you want me to go ahead and tackle chief complaint a little bit?
Yes, please.
All right. Well, it sounds like we have a younger patient, 34, who has also an acute presentation of both sensory deficits and motion deficits that are both appearing on the same side. Um, when I start to think of both sensory and acute things that are happening in kind of this acute period, two things that come to mind are seizures and then vascular deficits. Um, I think I would be concerned too about kind of differentiating whether this is a more central process or more of a peripheral process. And I think it'll be helpful to know a little bit more about kind of the accompanying syndrome too, or whether there are other kind of nerves that we can pinpoint to guide us to more of a central presentation or peripheral. And then also whether there are more accompanying symptoms that are not necessarily neurologic. But other than that, I'm not sure that we can make too many conclusions from here.
I totally agree with what Sarah said, is that the first thing that we always want to think about is where do we localize the lesion? Like, do we have information to help us localize the lesion? And then based on the timeline and the clinical presentation, what is our differential for that localization? So I agree that thinking about the left hand numbness and the left-sided weakness, or uh, oh, we were told left hand numbness and left-sided weakness. I am wondering, is the numbness a like pinprick temperature issue affecting the spinal thalamic tracts, or is it a vibration proprioception issue that's affecting more the dorsal column, medial lemniscus? And that sensory deficit, I think, would be most helpful in helping us localize. I am presuming that this would be a spinal thalamic abnormality that with pinprick, temperature, maybe fine touch, that there would be deficits there. And when somebody has spinal thalamic deficits that's in the same limb as their motor weakness, then we're really localizing to either the peripheral nervous system, it could be like a brachial plexopathy, could be a radiculopathy, could be a individual nerve, a median nerve issue if it is like just left hand weakness and sensory deficits. So peripheral nerve issue, or if it's central, it's going to be contralateral brain. It's not going to be in the spinal cord if somebody's having spinothalamic deficits, because the spinothalamic tracts cross at around the level of the spinal cord, maybe like plus or minus 2 levels. But somebody who has a spinal cord lesion, like let's say a left-sided cervical spine lesion, that person is going to have left-sided motor deficits because the motor tracts, originate at the motor neurons that are contralateral and cross at the medulla and descend the spinal cord. And so left-sided cord issue is going to cause left-sided weakness. But a left-sided cord issue is not going to cause left-sided spinothalamic tract deficits. It's going to be right-sided spinothalamic tract deficits. And so thinking about this presentation, I'm wondering, what is the numbness? I want to hear more about it either in the HPI or indefinitely on the exam. And that'll help us localize if we're thinking brain, like contralateral brain, or potentially peripheral nerve, ipsilateral peripheral nerve, peripheral nervous system, and probably not the cervical spine. I want to hear more about it.
All right, well, with that, I will share the next aliquot. So this left-sided weakness, numbness came on all of a sudden 2 days ago, and she first noticed it while she was folding laundry, where she was not able to hold the edge of a pillowcase she was trying to fold, and she was not able to pick up her son's pacifier off the floor, and she was having trouble with texting. Um, and then she says she feels that the sort of sensory deficit in her left arm has been getting worse. It feels like it's heavy and asleep, distal to the elbow, but she's not having any tingling pins or needles. It's just a numbness. Um, and she thinks sh her speech is unchanged, but she feels that she's speaking more slowly than she was before. She denies any strike to the head. On review of systems, she denied any chest pain, shortness of breath, palpitations, nausea, vomiting, fever, neck stiffness, rash or skin changes, vision or auditory changes, no headache, no weight loss. She has no past medical history other than delivering a healthy baby 1 year ago after an uncomplicated pregnancy and delivery. For her family history, there is this sort of vague mention of heart disease or heart attacks in her grandparents on both sides of the family. Her only medication is a hormonal contraceptive. For her health-related behaviors, she says she smokes 1 cigarette per week socially, and will sometimes have a glass of wine with dinner at night, but not every day. She works as an office manager for a local optometry practice and denies any allergies.
All right. Well, I'm not sure still whether we've added much more to our localization, but I am interested to know whether there are more kind of motor deficits that she's not picking up on, because it does sound like she just noticed this weakness of her left hand in the midst of having to do like this kind of fine motor task of folding laundry. So there might be more deficits that she is not noticing that will come out in the exam. The kind of acute and progressive nature of this weakness and sensory loss gives me kind of like a compressive flavor, or potentially some kind of ischemic problem, whether it's like a compression on the kind of nerves that are feeding the lower arm, and maybe less so centrally. So this feels peripheral to me. but I would love to hear from Dr. Shi what you're thinking.
I think I agree that this story hasn't added a ton yet for our localization. I think the things that do add some useful information from the HPI is that it seems like she has a speech disturbance. Like, I guess she says she thinks she's speaking clearly, but more slowly than normal. And so it seems like if it's part of the same process that, this is affecting more than just the left arm limb. I think that um, I'm thinking more so that this is a central process, and contralateral could be like contralateral MCA territory, or a little bit of the small part of the corona radiata, or genu of the internal capsule, a little bit of the posterior limb of the internal capsule, something that is affecting face and arm more than leg. Um, I think that, as Sarah is saying, we wonder if there's more deficits than what's being told to us. I think that's especially a consideration when people are having left-sided deficits, because generally most people are left brain dominant and their right hemisphere is non-dominant, and people can oftentimes neglect what's going on with the left side of their body when they have a right hemispheric, brain lesion. And so in the HPI, I would, for somebody who, in general, we should always gather collateral history, but especially if somebody's having left-sided deficits, I think it's always helpful to hear from family or friends, anybody who's able to give us some collateral information about had they noticed anything in addition to what the patient's reporting to us. Things like left-sided visual spatial neglect, maybe they're bumping into furniture or into the door frame on the left side especially, or maybe they, were filling out a form or writing something and they were neglecting the left side of the form. It could be like actual, a visual hemifield deficit, but it could also be visual spatial neglect, even with full, visual fields or vision is fine, but they're just not paying so much attention to the left side of the world. They might also not pay so much attention to the left side of their body in terms of noticing other deficits, like maybe they're dragging their left leg and they're, not noticing that because of some right hemispheric issue. So I think that the fact that she's having a little bit of difficulty speaking, which I wonder, you had mentioned that it's slower than normal. I wonder if that is really, like, if she could tell us more about that. Like, does she feel like there's numbness in her mouth? Does her tongue feel numb? Is it difficulty articulating, or is it difficulty finding the right words? That would be a little bit unusual or less common for somebody to be right brain dominant and have their language hemisphere be the right side. But wondering if we could learn a little bit more about what she means by having some trouble speaking. I'm also curious what the contraception is what contraception she is using. I think I didn't hear that properly.
Yeah, I'm not sure that we heard what kind of hormonal contraceptive specifically, but whether it's estrogen containing or not, would that be kind of weighing into your risk stratification, or how would you use that information?
Yes, yeah. I'm curious exactly if it contains estrogen, which she's 34. She's not quite 35, but in women over age 35 who smoke, she smokes a little bit, but she still smokes, and maybe she could have a history of migraine with aura, or even just migraine. That yeah, and is in the chat, totally smoking and birth control both increase hypercoagulability. And so that could be a risk factor for arterial clots, could be a risk for her having ischemic stroke, which Sarah's saying is on the differential. And also venous clots, such as a dural venous sinus thrombosis or a cortical vein thrombosis, which can also cause neurological deficits, but usually it would be accompanied by headache. Also in the chat, we had seen that there's a question about how does age factor into her presentation? Sarah, do you want to respond to that?
I think my initial thought of like person who is postpartum, younger, maybe ischemic stroke is not necessarily as high on the differential as some other things like new seizure, migraine with, aura or um, some other things that may be more on the differential for her, like postpartum person with venous sinus thrombosis would be more likely for her. And then I guess the other thing doesn't really fit with this patient, but as long as we're talking about people who are at higher risk because of their age, uh, our CVS is another thing that could theoretically cause like neurologic deficits. She doesn't have the thunderclap headache that you would expect, but she would certainly be in at higher risk for her age.
Mm-hmm. Yes, yeah. And can you tell us a little bit more about RCVS? I think some people might not know what that
Yeah.
stands for.
Yeah, so reversible cerebral vasoconstriction syndrome. It causes kind of sudden constriction of the vasculature in the brain. It is on imaging, you will see blood, so like subarachnoid hemorrhage, and it can sometimes be called as a subarachnoid hemorrhage, but it is generally self-resolving. Um, and I think I don't want to say too much and talk over like say things that are incorrect, but I definitely know that it is more common if you like certain medications can increase your risk for it. And it's definitely something that you want to not misdiagnose because some treatments for subarachnoid hemorrhage can make it worse.
Hmm. Okay. Yes. So, yes, thinking broadly about the differential diagnosis, RCVS does come on the list. Like you're saying, it's not high in the differential because generally people present with recurrent thunderclap headaches. And the just, I guess, to talk about RCVS, since we're given an opportunity to talk about it, um, uh, reversible cerebral vasoconstriction syndrome is a disorder of cerebral autoregulation. That there is some there is dysfunction of cerebral autoregulation, and generally it's like a perfect storm situation where somebody is generally they're having some hypertensive disorder, maybe they have chronic hypertension, or especially in the um, third trimester and postpartum period, um, up to about 6 weeks or even 3 months postpartum, um, women, may have, preeclampsia or preeclampsia with severe features or some disorder like hypertensive disorder of pregnancy. And that definitely puts women at risk for RCVS. And then also the perfect storm of also using substances, especially some pathomimetic substances like cocaine or ecstasy, marijuana, nicotine are also can be contributors, and then liver dysfunction, renal dysfunction. Um, but I think we digress a little bit because we're not given a story of somebody with recurrent thunderclap headaches. Um, okay, so back to talking about age, I think one additional thing to add about a young person having relatively, having kind of a sudden-ish onset, having onset of neurological symptoms that may localize to the central nervous system, we should think about demyelinating disorders, the demyelinating diseases like multiple sclerosis. She would be like the perfect age group for that. And we heard that her symptoms started 2 days ago, and she first noticed the trouble with some minor tasks, and it sounds like it's progressed and now involving more of her left arm. We didn't hear exactly like how long it took to reach that um, progression, like how long it took to reach the current state she's in right now. If everything, it started and then within an hour, her symptoms were maximal like this, or within 5 minutes, or did it take like, the whole 2 days to progress to this point? But this could very well be a story of somebody with acute demyelination.
Yeah, and maybe when we go and get more history from her, then we'll hear about some things that she didn't really think about. And this is not only her first presentation of
Mhm.
MS too. So we'll hear
Yes,
more.
can we ask that? Has she ever had any
Ah,
neurological symptoms before? Does she get headaches? Could this be migraine with aura?
Are you ready for the next aliquot?
yes.
Happy to clarify that she's never noticed any neurologic symptoms like this before. And also happy to clarify on the hormonal contraceptive, she does take an oral estrogen-containing um, contraceptive pill. Um, all right, I'm gonna give the physical exam next. She is afebrile with a heart rate of 77. Blood pressure is 116 over 78. Respiratory rate of 16, saturating 100% on room air. Generally, she is well appearing and is not in any acute distress, other than being understandably very anxious to be in the emergency department. Um, she does not have any evidence of scleral icterus. She has a normal neck range of motion, normal extraocular movements. Pupils are equal and reactive to light. She has a normal heart rate and rhythm without any murmurs, rubs, or gallops. She has normal distal pulses. Pulmonary and abdominal exams are normal. For the neurologic exam, she is alert and oriented ×4 with normal attention and concentration. She has no dysarthria, and she has intact fluency and comprehension in conversation. For her cranial nerve exam, as I mentioned, normal extraocular movements, no nystagmus or ptosis. Facial sensation is intact. She does have left lower facial droop. Hearing is intact to voice. Tongue and palate are midline and elevate symmetrically. Shoulder shrug is intact and symmetric bilaterally. For her motor exam, the remainder of the motor exam, she does have 4 out of 5 strength in the left upper extremity compared to the right, which is most noticeable with her wrist extension, supination, and elbow extension. She does have normal reflexes. She does not have any abnormal movements. And then for her lower extremities, she does have 4 out of 5 strength with hip flexion. And she has mild bradykinesia with all movements of her left arm and leg. Her sensory function, it is decreased to light touch and to pinprick in the left upper extremity, only on the posterior forearm distal to the elbow. Her coordination is intact with finger to nose, but she does have slowed fine finger movements on the left. And her gait is normal. The next thing I will show, just because based on these exam findings, she was not activated as a code stroke given the time frame, but we did get her to CT as quickly as we could for a non-code stroke patient. So Simi, if you would be so kind as to show the CT images. I have this image and I have one more of the CT. And that arrow kind of gives it away, but
Oh, sorry. Can we take one step back and wanted to clarify, and I think this might just be a me thing. Um, you had mentioned that there's left lower face droop. Do you mind describing that a little bit, or do you mean like the left lower face is droopy, or like left lower motor neuron facial droop?
yeah, so it was only the corner of her lip
Okay.
that was drooping. Her forehead was intact, and she did not have any nasolabial fold flattening or ptosis.
All right.
Yeah, and I'll have after you have some fun with the CTA, I have one more picture to show you before the end of the aliquot.
Okay. And I know that clearly we're like looking at imaging now that is of the central nervous system, but maybe I can give Sarah an opportunity to talk about the localization a little bit more based on the exam.
Yeah. So when we're talking about her left side weakness, that's both facial and upper extremity. And I didn't hear the lower extremity exam. Was the strength
4 out of 5 to hip
okay
flexion,
on,
but
on the same side, left as well.
yeah, but
So
normal.
okay. So for what I'm hearing is mostly central nervous system signs, especially taking into account the facial droop sparing the forehead. Um, as far as whether it's upper extremity or lower extremity, if you have kind of a vascular territory that would be both, the ICA is one place that you can end up with both lower extremity and upper extremity weakness as well as base. If you have MCA, it is generally more kind of upper extremity face, and then ACA is more lower extremity. There's also like I think without looking at the imaging too much, you can think about like territories of where masses could be that could also give this kind of pattern. So I think kind of internal capsule could affect both upper and lower extremity. Um, but what are kind of your initial thoughts when you hear the exam?
Yes, yeah, I totally agree that we are hearing about left upper motor neuron facial droop, left arm weakness in many, or we were told it's like pretty much like 4 out of 5 in the left arm, although um, more affecting the, it sounded like triceps and wrist extensors and the supinators. And so kind of a weakness that looks a little bit like this, which is generally an upper motor neuron pattern of weakness. Maybe people have seen people who have suffered a stroke before that's affected their upper extremity, and oftentimes you might see somebody who maybe didn't recover well from that stroke or didn't get good rehab or has spasticity, not getting Botox. Like they oftentimes hold their arm flexed like this, and the leg is oftentimes extended because of the weakness predominantly affecting the extensors of the upper arm and affecting the flexors of the lower leg is like a general like upper motor neuron pattern of weakness, like somebody who's had a stroke. So we're hearing that that this is a very upper motor neuron pattern of weakness involving face, arm, and leg. And we did not hear that she has neglect, and she does not seem to have any cortical signs other than face and arm being more affected than the leg. So, cortical pattern of weakness, but no cortical signs of left-sided neglect, left homonymous hemianopia. Um, the sensory exam, I'm sorry, I didn't hear the sensory exam. What were the deficits?
Yes, just decreased sensation to light touch and pinprick on
Okay.
the posterior left forearm distal to the elbow.
Oh, I see. Okay, so a very small area of sensory loss that does involve spinal thalamic tracts. And so, of the sensory loss that this patient has, it is in the same limb as there is weakness. And so, like we were saying earlier, that would mean either contralateral brain or ipsilateral peripheral nerve. But we're hearing about so much more weakness than just, isolated to the like distal arm muscles. And so I'm still thinking that all of this is right-sided brain. But where in the brain, this is a pretty like minor, not minor, like this syndrome is not showing a lot of cortical signs. And so just seeing this patient in the emergency department, I wouldn't be, or, in the hospital or the clinic, um, I wouldn't be thinking that this patient has like a massive hemispheric stroke, that's affecting all their, affecting so much motor on the right side. Generally people would have cortical signs, but of course, their, patients are not always textbook, and they could have some amount of vasculopathy with collaterals, or they could have showered embolic events. So, it could be a bigger issue than like there could be more like there could be more areas of the hemisphere involved than what would be like textbook. But if this were to be like, kind of a textbook patient, we would say this is kind of like a pure motor syndrome with a little bit of sensory, or we could say it's a sensory, like a mixed sensory and motor syndrome. And so mixed sensory motor localized, there's 5 lacunar syndromes. They are pure motor, pure sensory, mixed sensory and motor, ataxia hemiparesis, and clumsy hand dysarthria syndrome. And so these 5 lacunar syndromes all have, relatively clear-cut localization that, if you see a patient with these symptoms. Pure motor would be face, arm, and leg weakness and no cortical signs. Like none of these lacunar syndromes have cortical signs. And face, arm, and leg weakness, that would localize best to contralateral corona radiata, posterior limb of the internal capsule, and anterior pons. And so it's all the areas where the motor fibers, we have the motor neurons that originate from the motor cortex, the most posterior part of the frontal lobe, that motor cortex, also called the precentral gyrus. All of those motor neurons, they come together, and those corticospinal tract fibers come together at the corona radiata, a good place to have a pure motor stroke. They go down the posterior limb of the internal capsule, a great place to have a pure motor stroke. Continue down the cerebral peduncle, go down the anterior pons. Anterior pons is a great place to have. I guess it's a place to have a pure motor stroke, and then the motor fibers cross at the medulla. And so those three locations, corona radiata, posterior limb, internal capsule, anterior pons, are typical locations to cause a pure motor stroke contralaterally. Somebody having a pure sensory stroke, that's really the contralateral thalamus. If somebody is having a mixed sensory motor stroke, so weakness of the face, arm, and leg, and sensory deficits of the face, arm, and leg, no cortical signs, that would be thalamocapsular, since the posterior limb of the internal capsule is right right adjacent to the thalamus. You can have a small lacunar stroke in that location, thalamocapsular, that causes contralateral motor deficits and sensory deficits. And then there's ataxia hemiparesis, so affecting motor tracts and cerebellar tracts, which oftentimes is contralateral brainstem or corona radiata, could also be the posterior limb. And then clumsy hand dysarthria syndrome is like a variant of ataxia hemiparesis, so similar localization, just smaller area. And so this patient is making me think that they might have a thalamocapsular issue, maybe more so the capsule than the thalamus. But we were, the images of the CT scan, CT angiogram flashed up, and, we have this arrow. And what area is that pointing to, Sarah? Or sorry to push you on the spot.
Well, it looks like we're very close to the like the cavernous sinuses, and where the the MCA would be kind of coming off. But this spot that we're seeing is very dark. So I'm not really sure exactly what this is. I would be tempted to scroll back and forth and try and figure out what it is.
Yeah, it looks like it's the internal carotid artery. I agree. I might need to scroll a little bit up and down to determine if that's the petrous. I think it probably is the petrous segment of the internal carotid artery before we arrive in the cavernous segment. And, distal to that would be the supraclinoid segment. But it looks like there's non-opacification of the right petrous segment of the internal carotid artery. And so that is a very large vessel occlusion, and certainly it can cause her symptoms. I just would expect her to have more symptoms than that occlusion is showing us if she is an otherwise healthy 34-year-old person who's never had any, vasculopathy issues before.
Yeah, excuse my
That's an image of her MRI. Sorry.
Sarah, you were going to say something?
Yeah. Does this look at all like what you would expect for a dissection for somebody of her story?
That's a great question. I would be surprised if this were a dissection that extended all the way to the petrous segment, because that's a very long dissection. Typically, when people have dissections of their cervical arteries, so the carotid arteries, vertebral arteries, generally it's lower down where there's our neck is so vulnerable. All these arteries are just right here, and normally when we dissect, it wouldn't be something like so much higher up. And so, if she did have a dissection in her neck, the cervical segment of her internal carotid artery, then for it to reach all the way to the petrous segment and to have it looked like a complete occlusion on that one slice, to me, it indicates that, it probably did not just happen. And so I want to ask her if she's had any neck trauma or, neck manipulation, been on roller coasters, fell off, had any trauma, all of that, in the last several months. And also if she has had any neck pain, and also any other, I guess she already told us no neurological symptoms before this, but kind of really digging, because it would just surprise me to have this be her neurological presentation of a dissection to that degree. That's like really massively dissected, or massively occluded. If it's from dissection, it's like really severe. Um, okay, but I guess moving the case along, Sarah, what do you think about this MRI? And what sequence do you think this is? And what are you seeing in what area?
Uh, this T2, is that where we are at DWI? Um,
Yeah, I believe it's a DWI,
DWI.
diffusion weighted imaging, which is a T2 weighted image, or like T2 based image. DWI
Okay.
comes off of T2 sequences.
Yeah. So we are seeing no what looks like no lesions on the left side of the brain, and only lesions on the right side. We see diffusion restriction. We would want to compare with our ADC if this is our DWI, to make sure
That's
that
right.
it's
And
acute.
so, sorry to
Uh,
interrupt, but we, most technically speaking, would reserve the term restricted
yeah,
diffusion to comparison with ADC. So it's
yeah,
bright on DWI, dark on ADC. In that case, we call it restricted diffusion. But if we only see the DWI, we cannot say it's restricting. We
yeah,
need to have the ADC be dark,
yeah.
which it probably is, but we don't have the ADC to look at right here.
Yeah, my question would be, would we have an ADC to compare with? And if we don't, was it dark on ADC? But we have these kind of scattered bright spots uh, that are mostly more central rather than kind of to the periphery of the brain.
Mhm.
Um, so similar to what our localization already was. Um,
Yes, yeah. And so this is the corona radiata. Some people might say part of the centrum semio valley, but it's pretty much just corona radiata. And so that makes a lot of sense for the mostly pure motor symptoms that we're seeing. I wonder if she has an additional lesion that caused her sensory deficit, but it's possible that maybe the most posterior part of the GWI hyperintensity is affecting sensory fibers. But indeed, as Sarah was saying, that this is all in the white matter. It's not at the cortex. Cortex is gray matter, and it's also not in the. We don't see the deep structures here, but in the white matter, that's where people have motor and sensory deficits, could have cerebellar deficits, because cerebellar fibers also traversing, so much of the brain, going to the frontal lobe also. Um, but the lack of cortical signs makes sense because the cortex is not involved. It's all deep structures, all mostly motor structures.
do we have any more fun images to review?
In the next aliquot, yes, but as of right now, I will just share with you the radiology reads for those
All
images. Um, for the CTA, we have narrowing of the right ICA through the distal part of the carotid canal and proximal right cavernous sinus. Ophthalmic and paraclinoid segments are also narrowed. Occlusion of the right supraclinoid segment with reconstitution at the carotid T, most likely due to collateralization from the ACA. There's mild narrowing of the left ICA through the skull base. Findings are concerning for moya moya. Thrombotic event is felt to be unlikely. That is what our radiologist said. For the MRI, there was ADC, it was dark on ADC in the same area. So that was read as small watershed infarcts in the right hemisphere, likely recommended related to the right ICA abnormalities. And then they essentially just said all the vascular stuff is better visualized on the CTA.
right. Well, that's very exciting. if this is in fact moya moya, I'm wondering if we're going to see our angiogram and our puff of smoke. I don't know. Dr. Shi, have you seen moya moya present like this before?
Yes, yeah, and actually, I think that this makes the most sense. As we were talking earlier about, shocking that she doesn't have a larger syndrome if she's an otherwise healthy, young person with no prior vasculopathy. How could somebody have an occlusion of their internal carotid artery and not have a massive syndrome? Well, if she has moya moya syndrome or moya moya disease, um, and it's been slowly progressive over time, which we want to know if she has risk factors for developing moya moya, which we can get into. But with whether it's moya moya syndrome or moya moya disease, things don't happen instantly. It's not like she suddenly had an occlusion of her ICA. With moya moya, it's the progressive narrowing of these large, generally anterior circulation arteries over time. And then there's the development of all these collaterals, which is the puff of smoke that's seen on a diagnostic angiogram. And because of all of those collaterals, when somebody does have a stroke from moya moya, it's generally not like holohemispheric, totally like massive, big stroke. Generally, it is smaller strokes in watershed territories like it is for her. And so I think that everything is making a lot of sense between her presentation, the localization of her deficits based on her history and exam, and then the imaging as well. That she comes with relatively sudden onset neurological symptoms that localize to a vascular territory. That we were saying, there's a lack of cortical signs. It must be in the deep structures. Well, it is in the deep structures, but the etiology is, something that is not super typical to have moya moya. But it fits very well with moya moya that she probably has had this progressive vasculopathy for months, if not years, and then suddenly, she had this watershed event, which I wonder if there was anything in particular that provoked the watershed event. Sometimes it can relate to hypoperfusion, and so was she hypotensive for some reason around the time that her symptoms developed? Was she having like some GI illness or dehydrated or ran a race or curious to know if there's something around the time that her symptoms started. But I think that all of this makes sense. Now the question is, does she have moya moya syndrome or moya moya disease? And the difference between those is that moya moya syndrome is moya moya, so the narrowing of these proximal artery, like cerebral arteries, which can start, oftentimes does start, like the narrowing starts in the cervical artery. So it's not just like intracranial. And that can also be a clue that, it makes, well, I guess a clue for really moya moya disease. But let me take a step back. So moya moya is the narrowing of these proximal arteries and the development of all these collaterals that are not like great collaterals. They can tend to, they can tear and bleed. So people with moya moya are also prone to hemorrhage in addition to ischemic stroke. With moya moya, it can be moya moya disease, which basically means that it's like genetic / idiopathic, or moya moya syndrome, which means that there's something causing it. So it could be like really severe atherosclerotic disease, or it could, I think like dissection would be really unusual. But I think is on the list for potential causes of moya moya syndrome. But like sickle cell anemia is, at the top of the list, which it seems like we would be told that, if she has sickle cell, and we're told that she has like no significant medical history. And other vasculopathies can also cause moya moya syndrome, like inflammatory or infectious vasculitis. But generally, those people have, people have a lot of other additional symptoms, and it would have to be like really severe, untreated for a long time to progress to a moya moya syndrome appearance. And so that seems unlikely. It seems um, like, you know, probably for her, it is moya moya disease. And so certainly she should see genetics, and, we should take a look at her CBC, get hemoglobin electrophoresis just to screen for um, sickle cell and thalassemia trait. Um, I'm curious to know how you guys worked her up.
Yeah, see me, if you would kindly show the cerebral angiogram, and then just for the sake of time, um because I have some more to get through. The read on this, no evidence of moya moya disease or moya moya syndrome.
Hmm.
On the angiogram, there is abrupt occlusion of the right ICA at the communicating segment, where there's preserved caliber of the petrous and cavernous ICA, suggesting a subacute rather than insidious chronic process. And then there, on the next one, see me if you're able to scroll down, there actually was good ACOM filling from the, so she was able to have that collateral flow
Wow.
across the circle of Willis.
Yeah, and so in this image, I guess just to point out to people who might not look at diagnostic angiograms so often, is that it's nice that they, in the upper right corner, they indicate to us that it's the left side of the brain, but that's the left, they're like shooting dye up the left internal carotid artery, which now we're able to visualize at least the anterior portion of the circle of Willis pretty well, so that it's the right the left internal carotid artery that dye is being shot up. And we can see at like the bottom of the page, there's like the cavernous segment of the ICA where it's kind of like looping around. And then we get to the ICA terminus, which bifurcates into the MCA and the ACA. And then there's a robust ACON that provides really good filling into the right ACA and right MCA. Of course, we're not seeing like backfilling down into the right um, internal carotid artery, but we are seeing that there's a very patent anterior circulation, like part of the circle villus. Okay, and so very interesting that on diagnostic angiogram, they did not see signs of moya moya. You had said that they saw abrupt occlusion of the right ICH terminus.
Yes,
So,
with
Okay.
none of the puffs of smoke. They did not see any of those.
Hmm. Okay. Could still be moya moya in the making, just no puffs of smoke yet because it hasn't been going on for so long to develop those collaterals that would be visualized as puff of smoke. Um, but very interesting. Was there other, um, or I guess I can look on this, on what is written here about the CTA that, there was all this written about narrowing, like, okay, ophthalmic and paraclinoid segments are narrow. Okay, ophthalmic and paraclinoid segments are narrowed. Then occlusion in the right supraclinoid segment, mild narrowing in the left ICA. Okay, I guess it's not too non-congruent with the diagnostic angiogram. Um, all right, tell us more.
Yeah, so I will finally give you some labs.
We did skip all of that. We just went straight to imaging.
Yeah, because we similarly we got very excited about the idea of moya moya.
Mhm.
But there's some other stuff in between. So her CBC and her CMP were totally normal. Her EKG showed regular sinus rhythm. She had an INR of 1.2, which on our labs is considered normal. She had a lipid panel with a cholesterol of 189, HDL of 67, LDL of 113, a little elevated, and triglycerides of 46. Her A1C was 5.1, TSH 2.2, We got a CRP, which was read as less than 3, and an ESR of 4. Um, I see you getting excited in the chat, Jeffrey. The hypercoagulable workup, ANA was negative. Cardiolipin was negative. B2 glycoprotein, factor V Leiden, prothrombin G20210A was all negative, and ANCA was negative. We got an infectious workup as well. We got VZV, HSV, RPR, HIV, hepatitis panel, and a tick panel because we are in Maine. All of that was negative. Um, and then the only thing we found with the rest of the stroke workup was actually on her TTE, which on a bubble study did show a grade 2 right to left shunt at the atrial level, consistent with a PFO. And then I'll leave you to discuss that, and then I have one more aliquot for the final diagnosis.
Well, this is a very exciting aliquot. We've got all of our room workup and infectious workup, which all seems to be negative. No smoking gun, hypercholesterolemia, or anything of that sort. But the PFO is definitely an interesting feature here. I think when I've been, and I'm not sure, maybe Dr. Shi can fill us in on real clinical experience, but when I've been taught about like paradoxical embolus from the venous side, I think of like a younger patient who might be like weightlifting and there's some sort of kind of big venous return that forces the clot to move. If the shunt is occurring regardless, I think maybe that probably makes that not necessary. But I would want to know what it looked like when it first happened, whether this was spontaneous, whether there were lower extremity Dopplers that were done. Yeah, what do you think about this, Dr. Shi?
Yeah, I'm thinking that in this very thorough stroke workup, at least for what we typically do in the hospital, certainly there is additional testing that would be done in the clinic, like additional hypercoagulable workup and I guess oftentimes in the hospital at Emory, oftentimes we do get additional cardiac imaging for patients with an embolic stroke of undetermined source. If we are not blaming the arteries as the sort as the pathology itself, but rather thinking that in this case maybe she did have a centroembolic process that just lodged in her right cervical petrous ICA, but because she has really good collaterals in her circle of Willis, she's still filling enough to have not had, like, she's still filling well and not, therefore, did not have a really large syndrome. It's not like she had like a carotid terminus occlusion. She had an occlusion that I believe ended in the cavernous segment. And so she was still able to have filling from the other side. So now I'm like reframing my thinking that
Yeah.
it's okay that she did not have a massive, like it's great that she did not have a massive
Yeah.
stroke, but why did she not have a massive stroke? I think now it's, making sense that I think because she has this occlusion that is not quite so distal in her internal carotid artery. And now the question is like, why does she have this long segment occlusion in her right internal carotid artery? And probably that's centroembolic. And of course, we want to do a really thorough centroembolic workup. So TTE, and probably we would follow this up with a TEE to visualize the shunt better. Although even from this TTE, we're told that it's a grade 2 right to left shunt consistent with PFO. It seems like maybe Valsalva maneuver was not required to show this PFO. So it seems like it's, I think it's very possible that this PFO is at fault. And I'm seeing mention of the rope score in the chat. So rope score is risk of paradoxical embolism score, which I always pull up on MD Calc. And I guess somebody maybe Simi could pull it up and we can just calculate her rope score right here.
Yeah.
But I think her rope score will be high because she does not have any pre-existing medical conditions, and she yeah, and for her young age, I think Simi's pulling it up. Simi, are you pulling it up?
I actually have it pulled up on my screen if you want me to just share it. Oh, see if
Oh, perfect.
Thanks, Sam.
yeah.
Great. So no history of hypertension, no history of diabetes. She does have a stroke right now. Or history of stroke. I feel confused. There's no history, but she currently has a stroke. Cortical infarct on imaging. Her imaging actually does not show cortical, at least what we saw was not a cortical infarct.
I think we had only checked her yes for smoker.
Yeah.
Hmm.
And then her age, can somebody fill this out? Or fill it out the way we want and then
Yeah.
tell us the score. For cortical infarct, it's no.
I think we have to click no again for the first two.
All right, 6 points. 62% chance the stroke is due to a PFO, 8% risk of 2-year recurrence. So that's a very high ROPE score. And, our next steps generally are we would ask cardiology to be aware of her, either see her in clinic or come see her in the hospital. Oftentimes a TE will be obtained, which is also part of planning for PFO closure if that is an option for her. And then we, of course, will do Dopplers, certainly of the lower extremities, but if there's any symptoms in the upper extremities, like swelling, redness, concern for DVT, then, getting Dopplers in those extremities as well. And then oftentimes we also will get a pelvic MRI or like pelvic MR venogram, looking to see if there's any DVT that is in the pelvis that is not well visualized on lower extremity Dopplers. And seeing if there's any obvious clot, in which case we would want to anticoagulate this patient, but also think about does this patient have a reason to be on lifelong anticoagulation, in which case it seems like that would we'd have to do additional testing with hypercoagulable workup and such, because if somebody has a reason to be anticoagulated, then usually their PFO is not closed. The treatment would just be to anticoagulate them. And certainly before PFO closure, it's in the guidelines to have a patient wear mobile cardiac outpatient telemetry or Holter monitor, ideally for a month before PFO closure. So PFO closure is generally never an emergency. The only times that I've seen it done are for young people where we are certain it is the cause of stroke. Maybe it's their second, not their first presentation, and they also don't have medical resources to get the PFO closed outpatient. But otherwise, we would never expect cardiology to close the PFO during this hospital stay right now. Everybody should have an outpatient cardiac monitor. And depending on the scenario, also some additional workup, like hypercoagulable workup.
Dr. Shi, I think, sorry, Sam, before you go ahead, I think there's an interesting question in the chat. I'm not sure who is it from, but it says, is a lacunar stroke a common consequence of cardioembolism? Does that factor in your thinking that the PFO could be the culprit or not?
Yeah, that's a great question. So no, generally we think of lacunar strokes as, so just strictly speaking, lacunar stroke, so small size stroke, less than 1 centimeter in size, generally just one single lacunar stroke. 90% of the time it's due to small vessel disease, and 10% of the time it's embolic. And so that could be vessel to vessel embolism or cardioembolic, central embolic. In this particular scenario, why it's always important to think about each patient individually. In this particular scenario, I think that centroembolic, cardioembolic is a possibility because of what we see with there being this occlusion in the neck. Like that occlusion had to have come from somewhere, and we ended up seeing, I guess, like kind of like quote unquote lacunar stroke, but really it's like more than just a lacunar stroke. It's like whole watershed stroke. So I guess maybe the question was not directed towards this particular patient, but I would not call this patient as having like lacunar stroke. I would say that she's had watershed stroke. And then the question is like, why does she have watershed stroke? Well, I think it's because she has this like large clot in her right internal carotid artery. Fortunately, proximal, or like, fortunately, like not so close to the carotid terminus. And so we're, there's still like good flow from the left side, left anterior circulation into the right. And that's why she didn't have this like, massive right whole hemispheric stroke.
Yeah, definitely very fortunate presentation. I mean, all things considered.
Yeah, really.
Yeah, Sam,
Okay,
are
Sam.
there any additional workup that we have that was done for her?
Yeah, just one more piece of information. As you suggested, Dr. Shi, we did Dopplers. They were negative. But the CT venogram pelvis did show May Thurner compression of the left common iliac vein between the right iliac artery and the spine.
Oh, interesting.
You were right
Even
on.
Turner. So, I mean, just like kind of a perfect storm. Or yeah, anyways.
Yeah, and then outcome, she was anticoagulated, did 6 months of apixaban, has had her PFO closed, and has made essentially a full functional recovery.
Wow. That is wonderful. And so, and excuse my ignorance, but for her May Thurner compression of the iliac vein, was there clot seen as well, or there's just compression and therefore like suspecting that she had a clot that like flew away?
Yeah, that was our suspicion was that the clot had probably been there, but it had flown up, gone through the PFO, caused the stroke. And we didn't see any left in there.
Mhm. Wow, what a very interesting case. But also very, a very a great teaching case because it highlights so many really important and relevant topics between talking about history taking, exam, localizing based off of that information, and then looking at imaging, thinking about, um, how do we make sense of this scenario of a not very straightforward case, and also what stroke workup do we need to consider in a young population, a young patient as opposed to, maybe a typical like vasculopath older patient. And then also thinking about the rest of the body, including the possibility for May-Thurner syndrome. And it's a really wonderful case. Thank you so much for sharing it with us.
Yeah, Sam, thank you for bringing this case. This is a really interesting one.
Thank you for both of your brilliant discussion. This was so much fun to hear from you both. And I'm very excited for Vale's incredible teaching points.
Yeah, thank you. No, this was amazing, Dr. Shi. We for sure have missed you and your amazing teaching. And sorry, you did an amazing job on the hot seat. I think this case really highlights, a stroke we see every day, but with some interesting characteristics that I think were amazing. And going back to the basics, I'm just going to share a couple of teaching points for the interest of time. I think we started highlighting the main equation of neurology, DDX equals tempo times localization. And Sarah started us, thinking, okay, could this be a vascular etiology? Dr. She also included an inflammatory etiologies, in particular, considering the context of the patient being a young female. And I think we'll often forget of this third component of the equation, which is the context. So you did an amazing job discussing about how this patient being young, being postpartum, and also taking into account the smoking history and the contraceptive history, I think really made or really highlighted how all of these could contribute for a seemingly, very healthy patient and that may have some risk factors for cardiovascular disease. And I also love the teaching points about lacunar strokes. I remember Dr. Shi teaching me about lacunar strokes back when I did my rotation with her, and I will never forget that pure motor strokes can localize to three localizations. So the coronary iliata, the posterior lip of the internal capsule, and the anterior pons. And the new teaching for me was that mixed sensory motor strokes can localize to the thalamo-capsular region, which I think it's very, very elegant and cool. So thank you for joining, and we hope to see you more, Dr. Shi. It was a treat to have you here.
Thank you so much. It was such a treat to be here. Have a great week, everyone. Thank you.
Bye, everyone. Thank you so much.